Hello, this is Katie Du Bois doing my case study for this week on peptic ulcer disease. In this case study, the patient is a 72-year-old white man with a history of homelessness, COPD, chronic alcohol abuse, chronic dementia, and multiple episodes of upper GI bleeding. The patient was admitted to the hospital with complaints of lightheadedness, syncope, and abdominal pain. The patient was a thin, elderly man in no acute distress. On admission, his blood pressure was 96/72, his pulse was 104 beats per minute, his respiratory rate was 24 per minute, and temperature was 98.9 degrees Fahrenheit. His conjunctivae were pale. The chest and heart examination were unremarkable. The abdominal examination revealed mild epigastric pain on palpation. The rectal and prostate examinations were unremarkable. The patient's stool was black and tested positive for fecal blood. The remainder of the physical exam was unremarkable. On admission, the patient's labs were the following: hemoglobin 4.1, hematocrit 12.9%, albumin 2.6, white blood cell count 11,900, and ethanol was less than 10, which was normal. The EKG, chest x-ray, kidney ureters, and bladder x-ray, or KUB, was unremarkable. The patient was admitted to the medical ICU where a nasogastric tube was inserted, which showed output containing coffee ground gastric contents that tested positive for blood. The patient was transfused with 6 units of packed red blood cells. The upper GI endoscopy was performed, which showed a large 5-centimeter gastric ulcer in the antrum along the lesser curvature. Biopsy specimens were taken of the ulcers and surrounding mucosa. The biopsy specimens showed necrotic debris consistent with an ulcer, and the surrounding mucosa showed acute and chronic inflammation in organisms consistent with H. pylori. There was no evidence of malignancy. The patient was treated with acid suppressive therapy and antibiotics and was discharged 5 days after admission. He was instructed not to take aspirin or drink alcohol. The first article that I chose was on patient education on the pathophysiology of peptic ulcer disease. Peptic ulcers are open sores in the upper part of the digestive tract that can cause stomach pain or stomach upset and can lead to internal bleeding. There are 2 types of peptic ulcers: gastric ulcers, which form in the lining of the stomach, and duodenal ulcers, which form in the upper part of the small intestine. Peptic ulcers form when acid erodes the lining of the digestive tract. This can happen when there is an excess of acid in the system or when the protective layer of mucus in the lining is broken down. There are 2 major causes of peptic ulcer disease, which include bacterial infection and the use of pain relievers such as NSAIDs. H. pylori infection is a type of bacteria that lives in the digestive tract and is present in 50% of people. Other risk factors include genetics, smoking, alcohol, psychological stress, and certain foods. The article also reviewed common signs and symptoms associated with peptic ulcer disease. They include upper abdominal pain or discomfort, feeling full quickly when eating, stomach pain, belching, or feeling bloated after eating, heartburn or acid reflux, nausea, vomiting, blood in the stools, which may cause stool to appear black or tar-like, and duodenal ulcers cause abdominal pain that comes on several hours after eating. The second article that I chose was Peptic Ulcer Disease in Healthcare Workers. In a study in Taiwan, healthcare workers were evaluated for the risk of developing peptic ulcer disease. Nurses and other healthcare workers had a higher risk for peptic ulcer disease than the general population in this study. Within 4 subgroups of healthcare workers, physicians and nurses had the highest risk of peptic ulcer disease, and pharmacists had the lowest. Higher job stress and more frequent rotating shift work might be the reason that physicians and nurses had the highest risk for peptic ulcer disease in this study. The prevalence of high work-related burnout was 66% in nurses compared to other healthcare employees. Many epidemiological studies have reported that peptic ulcer disease is related to rotating shift work. In this study, it was also noted that nurses had the highest percentage of shift work, 74%, compared to other healthcare workers. This study is important to healthcare workers, especially nurses and physicians, because we work high stress level jobs and often don't take care of ourselves during our shifts. With long work hours and different schedules, we need to take care of ourselves as well as our patients. We should remember to eat healthy meals frequently throughout the day and to de-stress outside of work and for us outside of school. The third article that I chose for this case study was irregular meal timing and its association with H. pylori infection. This study was conducted to evaluate whether an irregular meal pattern is associated with an increased risk of gastritis and H. pylori infection. A variation in meal timing over a prolonged period appears to be associated with an increased risk of symptomatic H. pylori infection and gastritis. Regular timing of meals may play an important role in the prevention of these two medical conditions. Deviating from regular meal timing by 2 hours or more was associated with a 13-fold increase of developing H. pylori with gastritis and a 6-fold increase in developing gastritis. So again, nurses need to take care of themselves and make sure that they're eating regularly at work instead of going prolonged periods of time without eating to prevent our increased risk of peptic ulcer disease and gastritis. Case study follow-up. The patient was readmitted 2 weeks later with a history of abdominal pain, weight loss, constipation, and fever. Laboratory data revealed a urinary tract infection resulting from Klebsiella, which was treated with antibiotic therapy. His hemoglobin was 8.2 and his hematocrit was 27.5. He was transfused with 2 units of packed red blood cells and discharged 1 week later on antibiotics and acid suppressive therapy. He was readmitted for 2 additional episodes of a GI bleed. Over a 2-year period, he received a total of 20 units of red blood cells. He was taken to surgery for a vagotomy and enterectomy with Billroth II reconstruction. He was discharged to a nursing home 2 weeks after surgery. Patient education on peptic ulcer disease is very important to prevent reoccurrence. Education on diet, meal timing, smoking cessation, not drinking, and avoiding NSAIDs are all part of the patient education that we should be teaching patients upon discharge. The patient in this case study had a history of dementia and chronic alcohol abuse, so he may not have been compliant with the therapy after discharge, or he may not have been able to afford medications and a healthy diet because he was homeless. In the follow-up of the case study, the patient had surgery and was discharged to a nursing facility, so that would be helpful with his follow-up care after surgery for his peptic ulcer disease and recurrent GI bleeds.